All right. Hello, everyone. Welcome to a Rafael Medina subspecialty case discussion. Today, the focus of the session is endocrinology. And I'm so excited that we get to learn from the case by Dr. Rob Weber, who's an endocrinology fellow at UCSF. And we're going to try out a cool new format today where Kirtan and I are going to be tackling the case and that tackling the case that Rob presents, and then also hearing Rob's wisdom after we all discuss. So we're really excited to try this out. And Rob, thank you so much for presenting this case. How are you doing this morning?
I'm doing great. Thank you all for being here earlier, an hour earlier than we expected when we scheduled this. I appreciate you all being here. Yeah.
Yeah, and I also just want to acknowledge that I know that the match kind of results come out, or the initial results come out today, and I recognize that it's 30 minutes into the session. So I just really appreciate you all for being here. And for me personally, there is no other way I would rather spend this morning than learning about endocrinology with you all and discussing with Kirtan and learning from Rob.
Great.
Kirtan, how are you doing this morning?
Hi, thanks, Mary. I'm doing great. Thanks to Dr. Weber for bringing a case to us. We are excited to learn. And also thanks to Tensu and Harry for helping with the whiteboard. And lastly, prayers and best wishes to everybody who are waiting for the match results. I'm sure that by the end of this 1 hour journey, we will have nice case result as well as nice match results. Okay, so fingers crossed.
Exactly.
Sorry.
Well, I'm just so excited to learn from this case. So maybe we can dive right in, Rob, and yeah, start hearing the first aliquot.
Sure. So this case started as an admission for a code stroke. And the story is that an 85-year-old woman woke up at 6 a.m. and went down to the breakfast table, where she was found by her family to be slurring her words and unable to use her spoon, she's right-handed, to feed herself for breakfast. She had no loss of consciousness, and as far as they know, no fall, no head trauma. So they called EMS, and when EMS got there, the finger stick glucose was 73. And so she was given a dose of IV dextrose and brought to the hospital. By the time they got to the hospital, the symptoms had resolved. She was back to her normal self. She got a CT head and a CTA anyway, and those were both negative. And so I guess I'll stop there and say, what do you think about that so far? And do you have an approach to hypoglycemia?
Yeah, definitely. I mean, this is a really interesting start to the case. So, I think that the main problem that we're trying to solve here is hypoglycemia. And my first thought when I think about hypoglycemia is wanting to understand if this is true hypoglycemia. So before kind of running our schema and going through the different approaches, wanting to make sure this is true hypoglycemia and we're not being fooled by pseudo hypoglycemia, for example. And there are kind of two ways I initially think about that. So first, I think about Whipple's triad. And Whipple's triad teaches us that to have true hypoglycemia, we need to have symptoms of hypoglycemia. We need to have a lab measurement that shows hypoglycemia, and then resolution of symptoms with treatment. And I think just from this aliquot, it looks like you could make an argument that those three components of the triad are met here. So kind of the patient being found kind of slurring her words, unable to feed herself breakfast. I think it's totally reasonable that a code stroke was called because that could most definitely be symptoms of a stroke, but those could also be symptoms of hypoglycemia. We also have the second component of the triad, which is the low blood glucose of 73. And another way I'm interpreting this data is that there has been resolution of symptoms with the administration of dextrose, because by the time she arrived to the hospital, the symptoms had resolved and the CT imaging was negative. So my interpretation of this data is that those three components of Whipple's triad have been met, and I'm assuming that this is indeed hypoglycemia. If I actually learned from the CP Solvers Academy that if you are concerned about pseudo hypoglycemia, one of the things that you could do to explore that is get a simultaneous finger stick glucose and venous glucose, because, for example, if you are concerned about pseudo hypoglycemia, um, if you have pseudohypoglycemia, both of those measurements, they would be discordant. So for example, if you had if only the finger stick glucose was low, but the venous was normal, that could be from local hypoperfusion to the digit from hypotension or Raynaud's, for example. But if you had the finger stick that was normal, but the venous that was low, that could be from a lab processing error. Maybe there's like high cellularity in the case of polycythemia, that's consuming all the glucose. Maybe there's a lab measurement delay. So in summary, I think when I see hypoglycemia, I want to make sure we're not being fooled by pseudo hypoglycemia. I go through the Whipple's triad, and then ultimately my next step will be to understand the mechanism behind this, if this is insulin mediated or not. But we can kind of dive into that into further aliquots. But I'm curious, Rob, if you have any advice about, like, do you always consider kind of pseudo hypoglycemia right up front? Or what are the initial things that are going through your mind when you're confronted with hypoglycemia?
Yeah, I completely agree with everything you said, which was well done. I would say finger sticks in general can have a lot of issues. So if you think about what it's measuring, you poke the finger and you're getting some blood from these tiny capillaries, and then oftentimes they're even like squeezing it out a little bit to get a drop of blood. That can often have false lows. On the flip side, I've seen it also have false highs. Like for example, if the patient was eating something sweet. And so really the gold standard is the serum, because that's what the brain is experiencing. That being said, so I'm always skeptical. But that being said, the clue here is that we do have Whipple's triad being achieved. And so probably the finger stick glucose is accurate. Probably she was a little bit low. And then, 73 is actually not that low for most people out in the wild. Like, especially for women, there's a little bit of a lower cutoff in the outpatient setting, where 73, you wouldn't expect someone to become neuroglycopenic, which is what this is called when they have such severe symptoms. So that if anything, the finger stick might be a little off in the high direction, but I agree with you. Yeah. So I'll bring you to the second aliquot then. So while she was in the ED, recovering from her CT scans, her symptoms recurred. And they did, this time, a paired point of care and serum, and it showed a glucose of 55. And so she was started on a D10 drip, and the glucose was stabilized near 100. And then at this point, I'll just give you some of her background information. So a lot has been happening to this woman in the last few years. Over the last couple of months, she's been having some bizarre behaviors, what she calls her sleepwalking. So she's been outside the house a few times, confused, disoriented, lost, and then doesn't have a memory of these episodes afterwards. And she's had diabetes for many years, and she has a glucometer at home, and she notices that she has been running low. And she has to snack a lot. And it's gotten to the point where her family moved her from living independently into their home so they could watch her and make sure she snacks all the time. And that's been going on for a few months. For the past 2 years, the patient has lost 110 pounds from about 240 pounds. So almost half of her body weight. And she ascribes it to decreased appetite. Food doesn't quite taste the same anymore. And she's not too worried about it, because she's like, I look great. I've lost a lot of weight. I'm feeling satisfied with this. Over the past 5 years, so before that, she used to have diabetes on metformin, but her A1C improved, and she was able to stop all her medication. Uh,
Perfect.
do you want me to give you? I'll just give you the meds and the social history, which is not anything that will add too much, but just for completeness. So for meds, she has hypertension and she's on losartan 50 milligrams. She has hypothyroidism and she's on levothyroxine 50 micrograms. She used to be on metformin, no longer. No family history of any endocrine diseases, and no no like drinking or substances.
Thank you. Thank you, Dr. Weber, for sharing that information. So now approaching the case so far, what we have. So initially we were worried that this patient's symptoms were due to hypoglycemia and maybe the sugar levels were not too low, but then we know that the threshold to develop the symptoms of neuroglycopenia depends on how well your sugar is controlled. So for example, if you have repeated episodes of hypoglycemia, then sometimes people develop hypoglycemia unawareness in which the sugar levels may be low and they do not experience anything. And on the other side, if you are too well controlled, then it might happen that your sugar levels might be little bit normal, but still you might develop symptoms. But the fact that our patient had another bout of slurring of speech and focal neurologic deficits while being on dextrose drip, and then the sugar levels are 55, now firmly establishes that this was hypoglycemia and we are not missing any other mimics of hypoglycemia. Now that we have firmly established the hypoglycemia, our main task becomes how we are going to untangle this mystery based on the past data. So Dr. Weber shared very intriguing point that this patient has been losing lots of weight and has been developing some sleep disorder kind of symptoms. Now, if the people develop symptoms only at the night, then we are tempted to think that maybe this patient has nocturnal hypoglycemia. But to be on the cautious side, we should also entertain the possibility that maybe the low sugar levels are just making you more vulnerable to develop this sleep disorder like symptoms, and maybe the patient has another pathology going on in the CNS as well. So although we are trying to solve the problem of hypoglycemia, I'm also open to the fact that maybe the patient has alternate process going on, which is worsened by hypoglycemia. Now, let's say for the sake of simplicity that it's indeed hypoglycemia, which is contributing to these nocturnal abnormal behaviors. Now, why would patient have hypoglycemia only at night, and how the profound weight loss can help us? So the association of diabetes and weight loss is very vague and nuanced, and I would say that only endocrinologists can better explain it. But from what I know, sometimes we think that people who have type 1 diabetes are more prone to have weight loss, and people who have type 2 diabetes are more prone to have weight gain, or they are, kind of on the obese side because of the insulin resistance. But the fact is that there is something known as brittle diabetes, and it's again a vague term. It can be applied to different circumstances. But the point is that when your pancreas is not producing insulin and glucagon in perfect proportions, based on how you have anabolic and catabolic state of the body, people can have weight loss, people can have weight gain. So we should entertain the possibility that this patient has pancreatic dysfunction at the core. Now, let's say we are explaining hypoglycemia by endogenous sources and not by exogenous sources. So far, Dr. Weber has told us that there is nothing in the medication which is pointing us towards iatrogenic hypoglycemia. But definitely in such circumstances, we should get the urine tox screen just to make sure that we are not missing sulfonylureas. We should ask about any over-the-counter supplements which people might be inadvertently taking, and they may not endorse to you when they are presenting when they are describing their symptoms that, hey, I take these pills, because they don't consider them as the pills if they are over-the-counter supplements. So we should ask for any over-the-counter supplements. Let's say it is coming from endogenous sources, then how we would figure this out? So the ideal way is that when the patient is in hypoglycemic phase, you obtain the insulin levels, you obtain the proinsulin levels, you obtain the C-peptide levels, and then there are various permutations and combinations that you can have. But before we dive into the intricacies of that, just one comment I wanted to make was that if we have so much weight loss, now insulin by itself is an anabolic hormone. So insulin raises the hunger and insulin promotes the weight gain. That's why we often see that people who are prescribed insulin often have weight gain initially before the diabetes gets well controlled and they become neutral or they go on the lower side of it. But this patient has weight loss. So how we could explain that? So it is possible that maybe this insulin is coming from a neoplastic source. So often it could be happening that the tumor, which is producing these excess hormones, is driving the catabolism, and that's why people are losing the weight. So these are the difference between anabolic and catabolic state, which we'll be exploring further. And I am excited to learn more about it. So Dr. Weber, do you mind sharing with us that when you see the weight loss and weight gain in relation to endocrinologic conditions, especially diabetes, how do you approach it?
Yeah, fantastic. I think you nailed it. I think just to add a little to your comment about looking for pills and substances, you also have to ask about the people they live with, because those are the substances that are in the house. So, for example, like if there's insulin in the house, does anyone take a sulfonylurea in the house? Like, is there some sort of medication error that's going on here? But I agree with you. I think like when we are when we have a case of hypoglycemia that we don't know the answer to, I think everyone thinks about insulinoma quickly. But excuse me, insulin is a weight gaining hormone. Like, for example, when people start insulin, they often gain weight. And you think about what it does, it takes sugar in the blood and it smushes it into adipocytes and other cells. And so it is weird. There's some tension here that this person is hypoglycemic and losing weight. And so I agree with you. Like, this pointed to me that there is some sort of catabolic process going on here. The other thing that we can get from the history is that whatever is happening, this is chronic. Like, this has been going on for years, at least 1.5 years, if not longer. And it is still happening right now because, she got into the ED and she became hypoglycemic again. She has to snack all the time. So something has been brewing for a long time, and it's going on now. And I think it makes sense why she's not having maybe the classic symptoms that we think about with hypoglycemia, which are sympathetic symptoms like sweatiness, tremulousness, heart racing, and a sense of like, I need to do something, or there's impending doom. That trigger is dampened if it's repeatedly stimulated. So that's another clue that she's not having those symptoms. That trigger is dampened, and she has what we would call hypoglycemia unawareness at this point, which is dangerous because if the patient does not know to like intervene and eat something, they can go very low to the point that they have seizures or something, or coma. So that's what I was thinking at this point. I also think, like, to lose half of your body weight without drastic changes in diet or exercise is very remarkable. And even with diet and exercise in clinical trials, for example, people tend to lose 5 to 10% of their body weight. And that's like with checking in with the clinical trial people, with getting like nutrition coaching and all of that. So 5 to 10% of your body weight should be like your threshold for what is reasonably achievable without something else going on. So I like you, Kirtan, are worried broadly about some sort of catabolic state. And I think the differential for that is large. Tumor, like you said, Cushing's disease, like you said, or could be Cushing's disease, could be exogenous steroids. But what's weird about those two is that they would cause hyperglycemia, not hypoglycemia.
Perfect. Excited for more data, Dr. Weber.
All right, more data. Always more data. Let's see. Let's go to the exam. So on temperature, 37. Blood pressure was 150/56. She had been rushed out of the house and hadn't taken her medications that morning. Her pulse was 76. She was 94% on 2 liters. And what was remarkable about meeting her is that she was fit. So she had temporal wasting. She had scalloped clavicles where, the trapezius is so prominent, and then there's a big space in between the clavicle. She had no gum hyperpigmentation. She had no goiter. She had markedly diminished breath sounds on the right, in the middle, and at the base. Her abdomen was flat, not obese, and there were no violaceous striae. And then for her extremities, she had a lot of redundant skin in the upper arms and really no muscle at all. So, for example, like if you put your arm around her biceps and just tried to grab like the part of it that was the biceps, it was almost nothing. It was mostly bone and skin. And she had marked decreased muscle mass in her thighs. She had no rashes or bruises. For her labs, her white count was 6, her hemoglobin was 11, her platelets were 120. Her basic metabolic panel, I'll say, everything was within normal limits, but I'll highlight that the creatinine was 0.62 with an estimated GFR of 89. Her liver function tests included an AST of 15 and an ALT of 14. Her alk phos was 69 and her T-bili was 0.4. And then there were some initial investigations into some of the things that can cause hypoglycemia. So a lactate was 1, a TSH was 3.6, a cortisol was 12, and they did the stimulation test and it went up to 28. And anything above 18 is considered sufficient. An A1C was checked and it's 4.9. And I'll stop there.
All right, this is a lot of really interesting data to sift through. So I'll kind of summarize where we are right now, and then I think what I'm trying to figure out at this point is the mechanism at a high level of the hypoglycemia. So the summary so far is that this is an 85-year-old woman with a past medical history of diabetes, hypothyroid, who came to the emergency department because of a code stroke, but was found to have hypoglycemia that initially improved with dextrose, but recurred. And importantly, this is in the context of a more chronic catabolic process that we are also seeing kind of the signature of on physical exam. So for the physical exam, Rob mentioned the temporal wasting, the scalloped clavicles, the really decreased muscle mass. So all of that to me is really pointing to the chronicity of this catabolic process. And Rob, I would love to hear your teaching on this, but one of the ways I've learned to approach hypoglycemia is to understand the mechanism and to understand if this is driven by excessive insulin that's often like a timing problem. So it's too much insulin when the glucose is not high. So that's insulin mediated, or is it non-insulin mediated? And my understanding of that is that that's really a consequence of the deficiency of these counter-regulatory hormones like cortisol or catecholamines. And exactly as Kirtan said, insulin is an anabolic hormone. And oftentimes my understanding for insulin-mediated processes is that the center of gravity really is this hypoglycemia. You have a large amount of hypoglycemic symptoms, but really the dominant problem is the hypoglycemia versus in non-insulin mediated processes. There's a lot of other kind of systemic, there's more going on besides just the hypoglycemia. And so for me, I'm trying to figure out, is this more consistent with an insulin-mediated process or a non-insulin-mediated process? And I'm leaning more towards a non-insulin-mediated process. I would love to hear your thoughts on that, Rob, because I'm not entirely sure. I feel like I have going back and forth a little bit, but the reasons I'm leaning towards a non-insulin-mediated process is the chronicity of this, and also the fact that the center of gravity really is not just the hypoglycemia here. This woman has a lot of other concerning things going on in terms of the temporal wasting, et cetera. And this woman is clearly very sick. So for those reasons, I'm leaning more towards a non-insulin mediated process. And I'll kind of pause there because Rob, I would love to hear your teaching on if you find the insulin versus non-insulin mediated distinction a helpful one and how you helpful ways that you try to distinguish those.
Yeah, I love that. I completely agree with you. The first branch point when you get a hypoglycemia case is real or not real, which we already discussed, like with the finger stick and all that. Once you're convinced that it's real, then my next branch point is insulin mediated versus not. And I think insulinomas are extremely rare. So even at UCSF, we get like 4 a year. So we all get very excited. But the script for those cases is different. These people gain a lot of weight. Not everybody, but most of them gain a lot of weight. And they say like, I just have to eat all day to keep myself going. And if I don't eat, I become like foggy and I can't do anything. And so they're very aware. And this person just is almost the opposite of that. Like they are not that interested in food. They've lost 100 pounds. They don't feel the need to like eat to keep things going. They're kind of like it doesn't bother them, and then the weight loss rather than weight gain again. So I think, and it's not 100% true. Like we had one woman who insisted on training for her marathon while having an insulinoma. She did not gain weight, but that's pretty rare. So I think just from that alone, I'm already thinking that this is probably not insulin mediated. And then you have to, we did ask if there's anyone with insulin in the house, and there wasn't, but it would be weird for her, even when she was living independently, and then with her family to like be administering herself insulin. So, and of course we can test for that, which is coming up in the next aliquot. But at this point, I thought I was concerned that something else is going on, that I think we're more in the insulin independent pathway. And so the differential for that, I like the CP solvers approach to it, where it's like, there's a few different categories, like decreased intake. She admitted to us that she has some of that. Decreased gluconeogenesis with liver disease or kidney disease. We'll have to investigate that, but the labs don't scream that at us. Increased consumption, like from a Warburg effect, like she certainly has catabolism. Adrenal insufficiency is off the table. I saw someone in the chat be like, how legitimate is this? Stim test to 28. That is very legitimate. I think even the 12 is almost at 18. So we can take adrenal insufficiency off the table here. And then the last category is medications. And we asked her up and down about any sort of substances, and she really, that's all she was taking was on the list. And so none of those should cause hypoglycemia. So the one thing, well, obviously we'll get to the decreased lung sounds, but the one thing I noticed when I saw her was how thin she was, which I tried to capture in the exam. And that raises a red flag for me, which is that the creatinine is no longer reliable for kidney function. Because remember, like it comes from the muscle cells. If you don't have that many muscle cells, your creatinine is always going to look great, no matter what, even if your kidney function is not doing that well. So that was one thing that I was thinking about in terms of our non-insulin mediated approach. And then let's see, we also, the A1C, pretty low for someone with a previous history of diabetes, and might just be capturing a lot of these hypoglycemic episodes.
Can give us more, Dr. Webb?
What's that?
More information. We can get more information.
Oh yeah, sure. Okay, sure. All right. So this came like kind of out a little bit out of order, but that's like how it is when you're a consultant. Sometimes you get like extra data up front. So the overnight team actually did the workup for insulinoma. So so they turned off the D10 drip and they let the glucose drift down. And what you want to do is let it drift down to less than 50. and then you send all these labs. And so they sent a insulin level, a C-peptide, a proinsulin, a sulfonylurea screen, and a beta hydroxybutyrate. So the insulin was below the limit of detection. The C-peptide was 0.2, and the normal range is 0.8 to 3.5. The proinsulin was also undetectable. The sulfonylurea screen was negative, and the beta hydroxybutyrate was 0.25. And I'm sorry, I should have said up front, the serum glucose that they achieved at the time was 63.
Perfect. So expanding more on this data, we are into the zone of what Madelina was telling us earlier, that given the fact that patient has so much catabolism, we are already thinking more about non-insulin mediated condition. And now with the results which we have, that when the sugar levels were extremely low, the insulin was also undetectable and proinsulin was also undetectable. So this kind of rules out insulinoma, if not completely takes it off the table, but it definitely makes the suspicion way lower. And before diving deep into the causes of hypoglycemia and weight loss, I just wanted to take a step back and explore this possibility. There's think of this patient, if you are taking care in the real life, that you have a patient who has hypoglycemia but also has profound weight loss. So if we try to keep the hypoglycemia off the table for a while, we should figure out that why this patient has such profound weight loss, because this degree of cachexia is unusual. So we should think that, okay, if this patient has systemic malignancy, how should I approach it? Should I pan CT this patient? Should I do some PET scan to figure out that why this patient has so much catabolism going on? And once I have a handle on why this patient is so cachectic, let's say I found the answer that this patient has a lung tumor. Maybe that lung tumor caused collapse of the right lower lobe, and that's why the patient has decreased breath sound. Maybe the patient has right-sided pleural effusion. That's why the patient has decreased breath sounds. And once I localize the pathology that this is the tumor, either lymphoma or solid tumor, and maybe that's why this patient has so weight loss, and then we can figure out the hypoglycemia part. So that's the one way to look at it, but it's good that the medicine team already did the preliminary workup overnight, so we are in a good zone. So thinking about the non-insulin mediated causes of hypoglycemia, the first thing that I am thinking of is pancreatic insufficiency. So we should get a really nice CT scan and we should see that how is pancreas looking? Is the pancreas really atrophic or not? Because if pancreas is really atrophic, you could imagine that it wouldn't have any ability to secrete insulin or other hormones like glucagon, which are counter-regulatory hormones and which are supposed to raise your glucose levels. And we know that people who have chronic pancreatitis also will have malabsorption. And not all the people who have pancreatitis will complain of chronic diarrhea, depending on which state they are coming in the hospital. So I'm interested in knowing the state of the pancreas itself, whether they are atrophic or not. And if they are indeed atrophic, then we can dig deep into the causes of the same. Let's say pancreas are looking fine and it's not pancreatic insufficiency. Then how we should approach this? Now that insulin levels are low, we are thinking about insulin-like factors which could lower the sugar levels. Now, sulfonylurea and drugs like insulin secretagogues, we say, will also tend to raise the insulin levels. So those things should not be on our radar now because insulin was low. What about IGF-2 like factors? So we know that IGF stands for insulin like growth factor. So the way IGF works is it also increases the cell's ability to metabolize the glucose. And just the way insulin causes hypoglycemia, IGF will also cause hypoglycemia. Now, one important concept to remember is that IGF comes in two forms, IGF-1, IGF-2. Now, IGF-1 is what we often explore in the realm of growth hormone excess states. But in hypoglycemia space, we think more about IGF-2 because it's the insulin-like growth factor 2, which has such pharmacokinetics in the body that it has access to all the insulin receptors and it can activate it to cause hypoglycemia. Also, like we know that every hormone in our body has binding proteins. So IGF-2 has like binding protein, which is known as IGF binding protein 3. And what happens is that in some people, the levels of IGF binding protein 3 are low in pathologic states. And that's why the IGF-2 levels may be relatively high. The free IGF levels will be high. And that's why it can cause hypoglycemia. And the reason why I am speaking so much about IGF is that because I remember once when I was an intern year, we had a patient who had a mesenchymal tumor. So these mesenchymal tumors are very rare kind of tumors, like things like sarcomas, fibromas, and they can hide at different parts in the body. Sometimes they could be in the pleural space, in the pericardial space, in the retroperitoneum, and you won't even see them often. Like sometimes you need PET scan or advanced imaging to even identify them. And these tumors are notorious to secrete the IGF-2, and which can cause the paraneoplastic hypoglycemia. So that's one way to look at this problem, that maybe we could get IGF-2 levels, IGF binding protein levels to find out if that is what is driving hypoglycemia. And usually these tests are pretty sensitive. Like you won't get extremely false positive or false negative results because there are not many other pathologic conditions in the body which impact the levels of these rare substances like IGF-2. So that's one. The last part which I wanted to focus on, which is kind of rare, and we discussed about this in one of our recent Spaced Learning series episode on hypoglycemia, that when our body is in state of excess antibody production, let's say you have underlying lymphoproliferative disease or myeloproliferative disease or any other hematologic neoplasms, you often tend to produce excess immunoglobulins. Now, all these immunoglobulins are antibodies. And one thing which antibodies love to do is like to bind to other things, right? So antibodies can bind to insulin, antibodies can bind to insulin receptor, and depending on whether they are stimulatory antibodies or inhibitory antibodies, you can go either way. People can have drastic hyperglycemias. We have seen people who are on 500 units of insulin per day, 1,000 units of insulin per day, just because of paraneoplastic antibodies against the insulin receptors. And the other way around, people can drop to like 20s and 30s repeatedly because of the same antibodies if they are inhibiting or stimulating the receptors, depending on the proportion of it. So these are the things at back of my mind, that I will look at the pancreas, I will look at the IGF-2 levels, I will explore this rare possibility of insulin antibodies. And for that, I will definitely need the help of endocrinologists because I don't know how to interpret the levels of insulin antibodies. So Dr. Weber, can you tell us more that how would you approach this?
Yeah, that was great. I'm very impressed with your differential. You captured a lot of the exotic things that we were thinking about. Um, I guess first I'll just take a step back and talk about this test for the insulinoma. Like, why are we torturing this patient and making their glucose go low? And so the thing about a lot of things in endocrinology is with all the negative feedback loops, uh, tests have to be interpreted in their context. So, for example, a parathyroid hormone of 60 is normal, but a parathyroid hormone of 60 with a calcium of like 15 is abnormal. And so, for this test, we are letting the glucose go low so that we can see if the insulin is normal or abnormal. Because at that point, you would expect the insulin to be low at a low glucose. And there are also like a few different tests we're sending here. So the C-peptide, you might recall, is the little fragment of insulin that gets cut off when it is processed. And that sticks around in serum longer and is a more reliable marker. And then proinsulin is the pre-formed insulin that is not like fully processed. And so it is often released by tumors like insulinoma. And then someone in the chat rightly thought like, oh, weight loss and diabetes, should we be thinking about insulin deficiency or type 1 diabetes? And the beta hydroxybutyrate can help us there. So if there was truly a lack of insulin signaling, we would expect that to be high, that the catabolism would lead to a high level of ketones. And so the fact that it's on the lower end, and I'm sorry, I should have given you the normal range for that. It's 0 to 0.28. Tells us that there is at least some level of signaling there. In terms of like IGF-2 and insulin antibodies, these are tests that are uncommonly sent, and you can imagine they take a long time to come back. Oh, sorry. And so we definitely sent them, and but we did not get the answers until until after the patient left the hospital. But I agree with you. I think that the things on our mind were what's going on in the lungs. Could there be a stromal tumor there that is secreting IGF-2? Could there be an autoimmune driven process from like a receptor, an activating receptor antibody, for example, so that you don't need insulin, but the receptor is still activated? Or is it something else? And so I think we got a little more data. So the patient had a chest x-ray, which showed, like Kirtan predicted, a large right-sided effusion, but within that effusion, a 3 centimeter by 3 centimeter mass. And that mass was sampled. And the biopsy showed a stromal tumor called a solitary fibrous tumor. And also we got a cystatin C. It was 1.91 with an estimated GFR of 27. We also got a VBG, which showed a pH of 7.42. A CT scan of the abdomen was obtained, and the pancreas looked normal. The pending labs, which I'll give you at the end, were the insulin receptor antibody, IGF-2, and a paired IGF-1.
All right, this is so fascinating. So I think the new data here that's really standing out to me is the signal that we have in the lungs. And I think we were predicting that given the markedly diminished breath sounds on physical exam that that Rob heard. But so now we're seeing that there was a mass there that the biopsy shows was a stromal tumor consistent with solitary fibrous tumor. So I think, just to summarize where we are, so we confirmed that hypoglycemia was real. And then when we were thinking of the mechanism, we were leaning more towards the non-insulin mediated process. And through all of this, we were concerned of a catabolic process in light of the chronicity of this and this really significant weight loss. And one of the things, Rob, that you mentioned was I think the two things I have on the top of my mind is, should we be considering the Warburg effect, which my understanding is when you have this kind of excessive glucose consumption in the studying of cancer? I generally associate that with kind of lymphomas. So if we were concerned about that, we could send an LDH, for example. I'm So I think my mind is thinking, should we be concerned about the Warburg effect given how sick this patient is? Or is this, I don't know much about the IGF-2 that Kirtan talked about, so I would need to learn more about that. But my understanding is that because that mimics insulin, that would fall more into the insulin-mediated process. And my understanding is that we're more in the non-insulin mediated process. So I would love for you to correct me if I'm wrong there. But my mind is I'm still in the non-insulin mediated process. Given the chronicity, I'm concerned of, could this be a Warburg effect from a cancer? And I guess a question to you, Rob, would be, if we are given the differential of the Warburg effect, what types of cancers are most commonly seen that cause hypoglycemia and the Warburg effect? Like, in addition to lymphoma, what other things can cause that? And I think I'm just trying to understand a learning point for me is to how can we connect this stromal tumor with the hypoglycemia? Is it through the Warburg effect, or is there some other mechanism that could do that? That's where I'm at.
I'm with you. This was really testing like the limits of my knowledge, and at this point, I had to start like really looking things up. Uh, as far as I've seen, and as far as I know, the Warburg effect I think is most common in blood cancers, like you said. And what I expect is that there's some anaerobic metabolism going on there, like a lot of sugar is being consumed, and we would expect the lactate to go up. And here the lactate was 1. The picture is complicated though, because at this point the patient has received sugar a few times, and so I wasn't sure if this was like a fair enough time to measure the lactate. So could the Warburg effect be in play when she's out in the world over the last few years? I don't know, I have to be honest. And then um, in terms of like this solitary fibrous tumor, that was something I immediately like punched into UpToDate. And it is one of the tumors that can make the IGF-2. And so what is IGF-2? Well, as Kirtan said, like in the pituitary, there's growth hormone, and then that stimulates IGF-1 from the liver. IGF-2 is something that is produced more in development, and we don't think about it as adult doctors, but can act like IGF-1. And IGF-1 stands for insulin-like growth factor. So besides helping with growth, it can also stimulate the insulin receptor. And so if there's a tumor that is secreting IGF-2 abnormally, that can cause a mimic of insulin. And sometimes, just like how insulinoma makes the pro-insulin, tumors that are doing things like a little off can make an unprocessed form of IGF-2 called big IGF-2. And that is about like where I where I left it. Let me see if I had any other comments. The kidney disease. So I think, Maddie, before I jump in, do you want to say anything about the cystatin C?
Oh, no, I I feel like I don't know much about the cystatin
Oh,
C, so
oh,
maybe I'll
perfect.
punt that to Kirtan or to Rob.
Oh, sure. Yeah, Kirtan. Yeah, you are.
Oh no, Dr. Weber, please, you can go ahead. It's
Okay,
fine.
okay. So like it's like when you can't trust the creatinine because you're worried about the amount of muscle the patient has or another reason. A good backup test is the cystatin C, which is produced by any cell with a nucleus. So it's more of a fair test. And so, given the patient's cachexia, and what she described as like lack of interest in food, like things taste weird, we're worried about maybe some underlying kidney disease, and the cystatin C, is much lower than the GFR from the cystatin C is much lower than was predicted from the creatinine. So we suspected that this patient actually does have some CKD. Well, I guess we can't say CKD because it's just one measurement, but at least some AKI. And I think like looking back, when the patient when the patient's diabetes got better years ago and she was able to get off metformin, that in older patients is often a red flag for some sort of kidney disease. So some sort of developing kidney disease. So that made sense for us. Yeah.
Perfect. Thank you. Thank you so much, Dr. Weber, for this amazing case. And before I ask Maddie to share the reflections and again to Dr. Weber to share the final
Oh,
thoughts.
I have the last data. I have the last data.
Oh,
Oh,
well
sorry.
then you can give it now, Dr. Weber. It's
Okay,
fine.
sorry.
Yeah.
So the insulin receptor antibody, negative. The IGF-2 was 50, and the IGF-1 was 37. To consider an IGF-2 mediated cause, usually you would like the ratio between those two to be greater than 10. And that's because the IGF-2 can suppress IGF-1 by negative feedback at the same receptor. So in summary, we thought that most likely the cause was renal insufficiency and cachexia from poor PO intake, and less likely IGF-2, although you can't completely rule that out without removing the tumor and looking at it under the microscope. She was given, there's all sorts of fancy medications for hypoglycemia, like diazoxide, octreotide, to prevent the release of hormones. But in this case, since we didn't think that was going on, we just gave her cornstarch, which is something you can buy at the grocery store for like $2. And we just told the patient to mix 1 or 2 tablespoons in with her food and to eat it. And what it is it's a complex carbohydrate, so it just lasts longer. And with cornstarch, she was able to come off of the D10 drip. Her glucose settled in the 130s, and she was able to go home on that, where she ultimately decided to focus on comfort and not undergo further workup of her tumor.
Perfect. Thank you, Dr. Weber, for explaining the intricacies of interpretation. And I wanted to comment on one thing, which of course I will reflect more on, that we know gluconeogenesis happens in the kidneys and in the liver. So if there is dysfunction of those two organs, you can get hypoglycemia. And during the process of gluconeogenesis, you need amino acids like alanine, which comes from the muscles. So in people who are cachectic, often you don't have that source of gluconeogenic substance and you can get hypoglycemia. Now, the only part which is going against that, or which kind of doesn't explain everything, is that let's say you are not having enough gluconeogenesis, but that still is not a reason to have extremely low insulin levels, because your levels might be normal, but it won't be very low. So that also makes us wonder that what if this patient indeed had some degree of IGF-2 secretion going on, which was suppressing the insulin, because we know when the IGF levels go high, insulin will go low. And that's why rather than being physiologically normal, it's even undetectable when the patient had low sugar levels. So that is one way to look at it. And of course, there might be more complexities to it than just this. The other thing I wanted to mention was that these stromal tumors are like very rare. And when we had it once, we are talking about that how you need the staining on like histopathology to see if there were IGF-2 granules inside the stromal tumors, and which might tell us if this patient has GIST or not. And the other thing is that although IGF-2 levels might seem normal, but as Dr. Weber said, that we look at the ratio, because the reason why the levels may be normal is because of the binding proteins, as we discussed in previous LE cohort, that people might have different levels of binding protein. And depending on how much your binding protein is, sometimes even if let's say your levels are normal, but maybe you are measuring the total levels, maybe the free IGF-2 at the level of tissues is still pretty high because of the lack of binding protein. And that could be driving this insulin mediated signaling and can cause hypoglycemia. So very intriguing. The only definitive way to find out is, let's say if the patient eventually regains the weight by giving the nice PO intake and everything, and if the patient's hypoglycemia totally resolves while the tumor is still sitting there, then maybe we can say that maybe tumor was not contributing that much. But let's say if we replete the patient nutritionally, patient is eating normally, and still patient keeps on developing hypoglycemia, then we might think that, well, maybe it's the tumor which was contributing and we can take the tumor out. So I guess the response to treatment might shed more light in the future. So that's what I was thinking. So what do you think, Maddie and Dr. Weber, that how we should summarize this case and what's the final takeaway message?
I like your point about the insulin is undetectable. That is odd, but I think at a glucose of 63, I think it is okay for the insulin to be undetectable. I think that I like that actually. So I would not put too much stock into that in this context.
And Rob, this was such an educational case, and I really, really appreciate you for bringing it. And so just to clarify my understanding, would you mind explaining how you were thinking about the cause of the hypoglycemia in this case? Was it from the combination of the renal insufficiency and the poor PO intake, or how were you putting that together?
Oh, absolutely. Yeah. Sorry for not explaining that well. So
No.
so as Kirtan said, the kidney is responsible for a third of gluconeogenesis on its own. So if the kidney is not working, you lose that. Secondly, if the kidney is not working and renal toxins build up, it also inhibits hepatic gluconeogenesis. So even though the kidney itself is only worth 33% or a third, it might be effectively causing a further decrease in gluconeogenesis. Secondly, gluconeogenesis relies on stores of glycogen and other tissues, and in this to mobilize into sugar. And in this cachectic patient who has like no muscle, minimal fat, she has reached the end of her stores. And so, and this is a process that has been going on for years. So I thought it was more that she probably had this tumor making her a little nauseous, maybe some renal insufficiency making her nauseous, poor PO intake for years, cachexia on top of renal disease driving where we are today. And so I agree that the treatment is mostly increased intake. It's hard when someone is in cancer cachexia, it is difficult to increase PO intake. Like there's mirtazapine, but it doesn't work that well. And so she was sent home on insurers, but she ultimately decided, like, I've had a long life. I'm gonna like live my remaining time and just, you know.
Rob, thank you for that teaching. This was such a really interesting case to discuss, and I learned so much from you. And before we pass the mic to Tansu, Rob, I was wondering if you could maybe choose 3 teaching points that you would really want to highlight to the learners listening.
Sure. I'd say number one, if you're, which I think applies to, you know, most internal medicine doctors, if your older patient with diabetes is suddenly doing a lot better on their diabetes, that should be a red flag that there's something wrong, probably in the kidney, because the insulin will circulate. The insulin is cleared by the kidney and it's probably circulating longer. Number two, in hypoglycemia, the physical exam is really important to look for cachexia so that you get the clue that you can't trust the creatinine. And the places to look there are, you know, temporal wasting, the trapezius, the thenar eminence. But also, I just kind of like squeeze their arms and squeeze their thighs, and kind of get a sense for how much of that upper arm is muscle and how much of that is just skin. And that's been a helpful thing. And then I think the third teaching point in this case, maybe it's just the exotic thing that like IGF-2 mediated hypoglycemia exists and is extraordinarily rare.
Thank you so much, Rob. This was such a great hour to learn from your expertise about hypoglycemia. And Kirtan, it was so fun to co-discuss with you today. So Tansi, we'll pass the mic to you for teaching points.
Sure. Thank you so much, Rob, for this great case and awesome discussion with Maddie and Kirtan, as always. So in the teaching points, I have right here, first of all, the definition of hypoglycemia, and we utilize the Whipple's triad here. And what's Whipple's triad? So there needs to be symptoms of hypoglycemia, the lab proof of hypoglycemia, and resolution of symptoms with sugar, with treatment. And in our approach to hypoglycemia, first we need to differentiate whether it's real versus not real, meaning pseudo-hypoglycemia. And if it's real, then we think about insulin-mediated versus non-insulin-mediated hypoglycemia. And if it's insulin independent, not insulin-mediated, then we have 4 options. We have to check whether the patient has decreased intake of sugar, decreased gluconeogenesis for the causes of maybe liver and kidney disease, or is there increased consumption in the body of the sugar by malignant cancer cells, for example, which is known as Warburg effect. Or if there are medications at play, such as insulin, C-peptide, sulfonylureas. And we should also remember to ask other people in the household and what kind of medications they are using. And then we talked about the finger stick measurement of the glucose having issues, which can lead to type 1 pseudohypoglycemia. In the tiny capillaries of the fingers, there can be a false low measurement of the blood glucose. The gold standard is the venous glucose, but there are also some issues associated with that too, such as leukocytosis, polycythemia vera, paraproteinemia, can lead to pseudohypoglycemia in the venous measurement as well. So the presence of symptoms only at night for this patient made us think about whether there's only exclusively nocturnal hypoglycemia, or is there another pathology in the CNS that's worsened by hypoglycemia. And we also talked about the type 1 diabetes patients being more prone to weight loss versus type 2 diabetes mellitus patients being more prone to weight gain. And we talked about, since this patient had hypoglycemia and was losing weight, had also other signs of cachexia, we considered the possibility of a catabolic state. And we decided that the chronicity of the time course was apparent in the physical exam of this patient. We also talked about the tumoral overproduction of IGF-2 stimulating the insulin receptors and many causing hypoglycemia. We shouldn't forget about the paraneoplastic antibodies causing either hypo or hyperglycemia, depending on what they bind to. If they bind to insulin or insulin receptor, they can cause either hypo or hyperglycemia. And for ketones to be present, there needs to be insulin presence. So if we are seeing, if we are detecting ketones in a patient, then we can think that the insulin is at play here. In this patient's case, there were many reasons for her hypoglycemia, from renal insufficiency to poor PO intake to her cachexia. We should remember that kidney is responsible for 1/3 of the gluconeogenesis. And as the kidneys fail, the renal toxin buildup can inhibit the liver gluconeogenesis. And with cachexia, when patients don't have any stores to mobilize for glucose production, then patients can also experience hypoglycemia through this route. Thank you so much for this wonderful day and wonderful case. I hope you all have a great day.
Thank you so much, Tansu. Incredible, incredible summary. And big thank you to you, Rob, and thank you, Kirtan, for co-discussing together.
Yeah, thanks for having me. Good luck. Thanks for hanging in there during the match. Jeez.
Yeah. Best of luck to everyone who applied.
Yeah.
Bye, everyone.